My name is Dr. Wershba, and this talk is on Juvenile Idiopathic Arthritis, or for short, JIA. The learning objectives and the purpose of this presentation is to learn about juvenile idiopathic arthritis, referred to as JIA, also referred to as inflammatory arthritis. Rheumatoid arthritis is no longer used as a diagnosis in children. So JIA is a clinical diagnosis, meaning that there are no labs or tests. Therefore, it's important to recognize the signs and symptoms. There are 7 categories under the umbrella heading of JIA, which are useful to know because the presentation and treatment may differ. However, the subtleties are not the focus of this lecture, as this is an overview of JIA in general. It's also important to understand that JIA is associated with uveitis, or inflammation of the uvea. So overall, this presentation will demonstrate treatments for JIA and review the goals of treatment throughout. First, the definition, classification, and categories of JIA will be delineated, with focus on the examination findings of each. An overview of the treatment will be discussed. In addition, a brief description of uveitis will be provided. And finally, the prognosis of JIA will be included throughout the presentation as we talk about each subcategory. So what is the definition of juvenile idiopathic arthritis? By definition, arthritis is inflammation of a joint, usually presenting as swelling, stiffness, decreased range of motion, and with or without pain. So, inflammatory arthritis has no other etiology, meaning that malignancy and infection can be ruled out. This develops in children under the age of 16. JIA can involve any joint and is diagnosed, as we said before, on clinical exam. The distribution of joint swelling often indicates which category of JIA, and this is relevant to the rheumatologist who prescribes the specific treatments. A cardinal feature that differentiates inflammatory arthritis from other types of injuries or arthritis is the presence of morning stiffness lasting more than 30 minutes. JIA is the most common rheumatic disease in children and is as prevalent as diabetes, with an estimated 300,000 children affected. So, JIA is classified based on a diagnosis of exclusion. Therefore, it is necessary to rule out malignancy, infection, and trauma prior to diagnosing JIA. Since there are no specific laboratory findings, and it is often common to have normal labs, clinical exam findings are the most important and only way to diagnose JIA. So swelling, warmth, and/or stiffness must be present for more than 6 weeks prior to diagnosing JIA, since infections or post-infectious processes can present exactly like JIA, but should resolve by 6 weeks, if not sooner. The cutoff age for the diagnosis of JIA is less than 16. So, for example, if someone is seen at the age of 18, but reports symptoms that started when they were 15, then this is consistent with JIA. There are 7 subtypes of JIA, classified based on the pattern of joint involvement. Since the disease may take time to evolve, the JIA subtype is not certain until after 6 months of onset. The first type is Oligoarticular JIA, which is the most common form of JIA, occurring in 50% of children with JIA. This is previously referred to as Polyarticular arthritis and is arthritis involving less than 5 joints after 6 months' time. Usually larger joints such as knees and ankles are asymmetrically involved. It is rare for the hips to be involved. Oligoarticular arthritis usually presents in toddlers and preschool-age kids. So here is a typical presentation. A parent reports that their 2-year-old, who was previously walking well, one day woke up and had a gait change. The child is holding his leg in a weird position, or the parents note that there is swelling, yet the child continues to remain active, tries to keep up with his siblings, and rarely complains of pain. This is an important point, as pain is not a reliable indicator of arthritis in children. they tend to compensate accordingly. Also of importance is that uveitis affects 20 to 30% of children with oligoarticular arthritis. Exclusions for the diagnosis of oligoarticular JIA are listed in the slide. So uveitis is uveal tract inflammation that occurs with JIA, other systemic illnesses, or alone. The highest risk for uveitis is in children with polyarthritis or oligoarticular arthritis, children less than 7 years, and those with a positive ANA. It is the most serious complication of JIA since it causes blindness if left untreated. Since uveitis is often asymptomatic, the only way to diagnose it is with a slit lamp examination by an ophthalmologist. ANA positivity in a child diagnosed with oligoarticular or polyarticular arthritis under the age of 7 conveys the highest risk for uveitis. These children require slit lamp examinations every 3 to 4 months for at least the first 4 years after diagnosis. Treatment of arthritis when uveitis is present often requires systemic immunosuppression. The next type of arthritis is polyarticular arthritis, which includes both rheumatoid factor negative and rheumatoid factor positive arthritis. Poly refers to 5 or more joints with arthritis occurring in the first 6 months. RF positive or rheumatoid factor positive is not as common in children as it is in adults, and in fact, less than 5% of all kids with JIA actually have rheumatoid factor positive arthritis. Polyarthritis tends to occur in the toddler or the adolescent age group and is more common in females, with a ratio of 3 to 1. The distribution of polyarticular JIA is more symmetric, involving the small joints such as PIPs, MCPs, wrists, etc. Usually, children diagnosed with polyarticular arthritis have a worse course than those compared with oligo. RF positive, even worse. However, this does vary. The next type of arthritis we will talk about is enthesitis-related arthritis, also referred to as spondyloarthropathy or juvenile ankylosing spondylitis. Enthesitis is inflammation at the sites of attachment of ligaments to bone. Hence, enthesitis-related arthritis is a chronic inflammatory arthritis often accompanied by inflammation of these areas. Sacroiliac joint involvement is characteristic. There is a strong association with HLA-B27, suggesting a genetic component. There is also an association with inflammatory bowel disease. Spondyloarthropathy is more common in males. It occurs in the axial and peripheral skeleton most commonly. However, limitation of motion of the lumbar spine is usually a later finding and therefore not part of the diagnostic criteria in children as it is in adults. The uveitis associated with enthesitis-related arthritis is usually symptomatic, accompanied by redness, pain, and photophobia. Next, psoriatic and undifferentiated arthritis. So the criteria for psoriatic arthritis includes 2 of the following: dactylitis or inflammation of the finger, nail pitting, or psoriasis in a first-degree relative, along with arthritis in the patient. It is usually asymmetric, involves the SI joints or sacroiliac joints, and often includes dactylitis, also known as sausage digits. Children do not often have signs of psoriasis, so the family history is important. The onset of rash often occurs after the arthritis has been diagnosed, but sometimes a rash never occurs. Since skin findings can be subtle, it is important to look for lesions in the hairline, behind the ears, the scalp, or in the intergluteal creases. Exclusions are included for reference. Undifferentiated arthritis, as the name implies, includes arthritis that does not meet any of the criteria or meet criteria for more than one category. Systemic arthritis is a category which requires its own lecture, but briefly, the criteria include arthritis and at least 2 weeks of fever which must be quotidian, meaning recurring daily, for at least 3 days, plus at least one of the following: an evanescent rash, or a rash that fades away, generalized lymph node enlargement, hepatosplenomegaly, or serositis. Systemic JIA is often accompanied